You know, it's amazing when you think about how many people get IV meds every single day.
Right.
It's got to be like a cornerstone of modern medicine.
Oh, for sure, especially in cancer treatment.
I bet there are millions of infusions happening globally.
Right.
Every day.
Easily over 1 million.
Wow. That's a lot.
Yeah.
But have you ever, stopped to think about
About what?
what happens if those drugs, those life-saving drugs, they leak out of the vein?
Oh, into the tissues.
Yeah, what then?
That's a great question, and that's the hidden risk we're going to dig into today.
It's a bit scary when you think about it.
It can be pretty serious, and it's this thing called extravasation.
Extravasation. Okay, so that's the term.
Yep, the accidental escape of those IV meds.
Got it. And we're doing this deep dive specifically for you.
You got it, so you can understand this really important part of medical care.
Definitely to get a good grasp on this, we've pulled together a bunch of information.
A range of stuff.
Yeah, we got the official guidelines from UpToDate.
Always a good place to start.
For sure. And then some expert opinions from the Oncology Nursing Society podcast.
The ONS always has great insights.
Totally. And some practical advice from that Oncology for the Inquisitive Mind YouTube channel.
That's a good one. Very practical.
And a super detailed medical review from PMC.
So we're looking at this from all angles.
That's the goal. All right. So by the end of this conversation today,
yeah,
you're going to have a clear picture of what extravasation is.
Exactly.
The different types of drugs involved.
Right.
How it's prevented.
Huge.
And the steps to manage it if it does happen.
And all of that without making it overwhelming.
Without making your head spin.
Right. Giving you the knowledge in a way that's easy to digest.
Think of it like a shortcut to understanding this critical patient safety issue.
I like that analogy.
All right, so let's jump right in. What is extravasation exactly?
Okay.
And how's it different from, when a non-irritating fluid might leak?
You mean like infiltration?
Yes, infiltration. That's the word.
You got it. So extravasation specifically is when these drugs called vesicants leak into the tissue around the vein.
Vesicants. Okay, so that's a key word.
The vesicants, yeah, and these are substances that can cause serious damage to the tissues.
So they're not messing around?
Not at all. They can lead to blisters and even tissue death.
Like the tissue actually dies?
It can, it's that serious now. If a non-vesicant drug leaks out, that's what we call infiltration.
Okay, so the main difference is
the potential for harm.
The potential for harm, got it. So it's all about whether the leaking drug can cause real damage.
Precisely.
Now, how does this leakage even happen in the first place?
Right.
I mean, veins aren't just bursting all the time, are they?
That's a good question. So there are a few ways this can happen. Yeah. Sometimes the drug can leak out right at the spot where the IV catheter goes into the vein.
I see.
Or the catheter might actually puncture through the wall of the vein.
Ouch.
Yeah. Not good. And sometimes the vein can get injured during the insertion process.
Just from putting the IV in.
Exactly. Or even just through normal use,
And that creates a way for the medication to escape.
Yep. And it's not just standard IV lines we're talking about either.
So even those bigger central lines.
Those CV aids, yep. Even they can have issues that lead to extravasation.
What kind of issues?
It could be problems with the placement or a disconnection in the line, things like that.
Okay, that makes sense.
Yeah.
So when I hear about drugs that can cause this, I immediately think chemo.
Yeah, chemo's definitely up there.
But I feel like it's not just chemo drugs, right?
You're absolutely right. Well, a lot of chemo drugs are vesicants.
And there are lists of them, I saw.
There are detailed lists, absolutely, and those are super important for clinicians to know.
Yeah, seems like it.
But the thing is, many other types of medications can also be a problem.
Really? Like which ones?
The ONS podcast had some good examples.
Okay, like what?
Like contrast media.
You mean the stuff they use for scans?
Exactly. That stuff can cause serious tissue damage if it leaks.
Huh. I wouldn't have thought of that.
It's not just chemo. No, then there's promethazine.
Promethazine.
What's that for? It's often given for nausea.
Oh, yeah.
And calcium chloride or gluconate.
Okay.
And even amiodarone.
Amiodarone.
Yeah.
That's for heart rhythm problems, right?
Yeah, and that one can cause damage too if it leaks.
Wow. So it's not just cancer therapies we need to worry about?
Not at all. Lots of drugs can be a problem.
Okay, so we've got extravasation with these damaging vesicants.
Right.
And then the less severe infiltration of non-irritating drugs.
Exactly.
But the sources also talk about categorizing these drugs.
They do.
Like vesicants, irritants, and even others.
It's important to understand the different categories.
Right. So can you break those down for us?
Sure. So the main difference, like we said, is between vesicants, which can cause blisters, tissue death, maybe needing surgery.
Yeah.
And then there's irritants.
Irritants, right.
Irritants cause more local reactions.
We'll get what?
Burning, pain, redness, inflammation at the site, but they don't usually lead to tissue loss.
Okay, so that makes sense as a basic way to divide them.
Right.
But I remember that PMC article went into even more detail.
Oh, yeah, they had a whole bunch of categories.
Yeah, the exfoliants and inflammatories.
You're right.
How do those fit in?
So they offer this broader classification system. Beyond vesicants, they have exfoliants, which cause the skin to peel off.
Oh, wow.
Then irritants, which we talked about.
Yeah.
And inflammatories, which cause mild inflammation. And then even neutral substances, which ideally don't cause any damage.
So it's like a whole spectrum.
Exactly. They even have a table with specific examples for each category.
Which table is that?
Table 1 in that article, it gives a more detailed view of the effects these medications can have.
But ultimately, the biggest worry
is there a drug as a vesicant?
Because those are the ones that can cause lasting damage.
Precisely. So identifying those is super important.
Makes sense, but I was reading that some drugs can act differently in different situations.
You're absolutely right.
It's not always clear-cut.
It's not black and white, no.
So what do you mean?
Well, some drugs can have properties of multiple categories.
How does that work?
It depends on things like the concentration of the solution.
How strong it is.
Exactly, and the total volume that leaks out.
So a little leak might be okay, but a big one is trouble.
Basically, yeah. And cisplatin and the taxanes are good examples of this.
Taxanes, those are chemo drugs, right?
Yep. And even within the taxanes, paclitaxel is classified differently by different groups.
Really? So some say it's an irritant and some say it's a vesicant.
Exactly. The ONS actually classifies it as a vesicant.
So even the experts don't always agree.
That's medicine for you. Always some level of complexity.
True enough now within the vesicant category. I remember seeing a distinction between DNA binding and non-DNA binding agents.
Yes, that's a really important point, especially when we're talking about cytotoxic chemo drugs.
Okay, so what's the difference?
Think of it this way. DNA binding agents, these are like anthracyclines, like doxorubicin.
Doxorubicin, okay.
And alkylating agents, like mecloirthamine and bendamustine. These guys, they mess directly with the cell's DNA. It's core machinery.
And that's bad because...
Well, it can lead to more serious damage that's harder to fix because the cell can't repair itself properly.
Oh, I see.
Now, non-DNA binding agents, like vinca alkaloids and taxanes...
Those are chemo drugs too, right?
Yep, they're generally processed by the body more easily.
So less long-term damage?
Potentially, yes. They can still cause harm if they extravasate, don't get me wrong.
Right, of course.
But the damage might not be as bad or as long-lasting.
Okay, that makes sense. So understanding this difference can help predict how bad the tissue injury might be.
Exactly. It helps guide our management.
Okay, so let's move on to prevention then.
Prevention is key.
Absolutely.
Yeah.
So what are the risk factors that make extravasation more likely?
Okay, so for peripheral alveoli lines, the UpToDate guidelines talk about a few things.
Like what?
They say you should avoid using veins in certain areas for vesicant infusions.
Okay, which areas?
Like the antecubital fossa, that's the bend in your elbow.
Right.
And the wrist and the back of the hand.
Why those spots?
Because extravasations in those areas can cause serious long-term problems.
I see, and that's even for drugs that are just irritants.
Yep. They try to avoid those sites whenever possible.
I guess those areas move around a lot.
They do, and they might not have as much tissue to absorb any leakage.
So what else do they do for peripheral lines to minimize risk?
So proper securement of the line is crucial.
So it doesn't slip out.
Exactly. You use tape and a transparent dressing.
What's the transparent dressing for?
That allows for constant visual monitoring.
So you can see if anything's going wrong.
Exactly. And this is super important before any medication is given. You always got to make sure the IV line is working properly, what we call patent.
So what does it mean to demonstrate patency?
Good question. So when we check for patency, we're making sure the line's open and the fluid can flow through it.
Okay.
We usually flush it with a little saline solution and watch to make sure it goes in easily.
I see.
And very importantly, we also look for blood return.
Blood return, what's that?
So when you pull back gently on the syringe...
Yeah. You should see blood flowing back into the catheter.
Oh, so that means...
It means the tip of the catheter is inside the vein and there are no blockages.
Makes sense. And you do this before giving the medication.
Always before the medication.
Okay, so it's a safety check to ensure the line is where it should be and working properly?
Exactly. We don't want to start infusing until we're sure.
That's good to know. Now, what about during the infusion itself?
During the infusion, right?
It can't just be hands-off, right?
No, definitely not. Especially with vesicants.
So what do you do?
Continuous monitoring is key.
Mm.
You have to watch the patient carefully for any signs of pain.
Okay.
They might describe it as burning along the vein.
Ouch.
And you look for any redness or swelling at the site.
And what if the patient feels something?
They need to tell us right away. If they have any pain, leaking, anything unusual?
Immediately, any changes they notice?
Because that could be the first sign of extravasation?
It could be, and catching it early can really limit the damage.
So now what about central venous devices?
CVADs.
Yeah. We said they have a lower risk of extravasation.
Lower risk, but not zero risk.
Right. So what are the preventative measures for those?
So similar to peripheral lines, you want to carefully choose the insertion site.
Okay.
And make sure the device is placed and secured properly.
So no wiggling around.
Exactly. And the ONS podcast really emphasized this.
What did they say?
They said it's super important to always confirm good blood return from a central line.
Before giving the medication.
Before any vesicant, absolutely. A lack of good blood return could mean there's a fibrin sheath.
A fibrin sheath? What's that?
It's a buildup of protein that can block the flow of medication.
Oh, so the drug goes the wrong way.
Potentially, yeah. And that could cause it to leak out.
To the insertion site?
It could, or even track along the subcutaneous tunnel.
Not good.
Not good at all, and they were very clear about this.
About what?
Never use a central line to give chemo, especially vesicants.
Okay.
If you can't get good blood return.
Got it. So that's a big no-no.
Definitely, if you can't get blood return, you need to investigate further. Maybe do a dye study to see what's going on.
Okay, so those are some crucial never rules.
Definitely things to keep in mind.
So what about general preventative measures?
You mean for both peripheral and central lines?
Yeah, like overall best practices.
Absolutely. So taking a good history of the patient's vascular access is important.
Like, have they had problems with IVs before?
Exactly. Any difficulties with insertions, past infiltrations, or extravasations, history of blood clots, vein problems, anything like that.
Yeah, so you know what you're dealing with.
Right. And that can help you choose the best access site and technique.
What else?
The chemo regimen itself is a big factor.
Like what drugs they're getting.
Exactly. For continuous infusions of vesicants or drugs that are really irritating.
Yeah.
A central line is often preferred.
Oh, so you go straight for the central line in those cases.
Sometimes it's even mandatory.
Interesting.
Using ultrasound guidance when putting in peripheral IVs can also help. It improves the accuracy of placement and reduces the risk of damaging the vein.
Less poking around blindly.
Basically, and finally, regularly checking for blood return is super important.
Like how often?
It depends on the situation, you know. For a peripheral IV push, maybe every 5 milliliters of fluid.
And for a mini bag?
Every 5 minutes or so.
So quite frequently?
Yeah. And for continuous central infusions, it depends on the institution's policy.
Okay, you mentioned some very specific never rules for peripheral vesicants.
I did.
Remind us about those.
Okay, so never use a pump to give a vesicant peripherally.
So always by gravity?
By gravity, yeah, through a free-flowing line.
And why is that?
It allows for better control and quicker recognition if something's wrong.
Makes sense.
And the second never is to limit the duration of any peripheral vesicant infusion.
To how long?
30 minutes or less.
Oh, wow. So pretty short.
Yeah, the shorter time helps with detecting problems early and limits the amount of drug that could leak.
Okay, so lots of strategies to avoid extravasation.
Lots of strategies.
But what if, despite everything, an extravasation happens?
Then you got to act fast.
What do you do?
So the immediate steps...
And all the sources agree on this.
All of them. The first thing is stop the infusion.
Right away.
Immediately, and this is crucial, do not flush the line.
Don't flush.
No, and don't apply any pressure to the area.
Why not?
Because both of those things could spread the drug further into the tissues.
Oh, so you're just making it worse.
Exactly. You want to contain it as much as possible.
Okay, so stop the infusion, no flushing, no pressure. What next?
You actually leave the IV catheter or needle in place.
You don't take it out.
Not right away. There are a couple of reasons for this.
Okay, like what?
First, you might be able to aspirate some of the drug.
Aspirate, meaning?
Draw it back out. You use a small syringe to try and get as much of the drug out of the catheter and the surrounding tissue as possible.
Okay.
And second, leaving the catheter in gives you a way to administer a local antidote.
If there is one for that drug.
Exactly, if it's indicated.
So it's like a 2-for-1.
Kind of, and if the extravasation's in a limb, you also elevate the arm or leg.
Why do you do that?
That helps reduce swelling and pain.
Makes sense. And obviously you got to examine the site carefully.
Of course, looking for leakage, swelling, redness.
Like a detective.
Exactly. And a transparent dressing is really helpful for that.
So you can keep an eye on it.
24/7.
And it's the nurse's job to know exactly which drug leaked out, right?
That's right. Identifying the specific agent is crucial.
Because that determines what happens next.
Exactly.
Okay, so let's talk about thermal therapy using hot or cold compresses.
Okay.
It's not just about comfort, right?
Not just comfort. No, there's a specific reason for choosing one or the other.
So how do you decide?
It depends on the drug, whether it's cytotoxic, meaning chemo, or non-cytotoxic,
Okay.
and how the drug works, its mechanism of action.
Got it.
Generally, cold compresses are recommended for most cytotoxic vesicants and irritants.
Cold. Okay.
But there are exceptions,
Like what?
like vinca alkaloids.
Vinca alkaloids, those are chemo drugs, right?
Yep. And apophytophyllotoxins, like etoposide.
Okay.
And there's some debate about taxanes.
So those are the exceptions.
Yes, for those you wouldn't use cold.
Okay, so why cold for the others?
Cold helps with pain and inflammation.
Makes sense.
And more importantly, it causes vasoconstriction.
Vaso what?
Vasoconstriction, it means it narrows the blood vessels.
Oh, okay.
And that can help keep the drug localized.
So it doesn't spread as much.
Exactly.
And when is heat the better choice?
Heat is generally recommended for vinca alkaloids and apophytophyllotoxins.
Okay, so those are the exceptions to cold.
They are, and the reason is that cold can actually make the tissue damage worse with those drugs.
Really?
Yeah, it can increase the risk of ulcers.
So heat is better?
Heat can help increase blood flow and promote dispersion and absorption of the drug.
So the op can clear it out?
Exactly, and heat might also be used for some non-cytotoxic extravasations for the same reason.
Interesting.
UpToDate has some really good tables that give specific recommendations for cold or heat.
Oh, so those are like the cheat sheets.
They are, they list tons of cytotoxic and non-cytotoxic drugs.
So clinicians should definitely check those out.
Absolutely, they're super helpful.
It's important to have those guidelines because it's pretty complicated.
It is. There are a lot of nuances.
Okay, so now let's talk about antidotes.
Antidotes, yeah.
It's got to be reassuring to know that there are treatments for some of these extravasations.
Oh, definitely antidotes can be real game changers.
So tell us about them.
So one of the best examples is dexrazoxane.
Dexrazoxane, okay.
It's the specific antidote for anthracycline extravasation.
So like doxorubicin.
Exactly, doxorubicin and other anthracyclines.
How does it work?
Well, it does a few things.
Okay.
It chelates intracellular iron.
Chelates meaning what?
It binds to it, basically, and that helps prevent the formation of these damaging oxygen-free radicals.
Interesting.
It also inhibits an enzyme called topoisomerase to beta.
Okay.
And that enzyme is involved in anthracycline-induced cell damage.
So it's a multi-pronged approach.
You got it. And it's given intravenously over 1 to 2 hours for 3 days in a row.
3 days. Wow.
And ideally, you give the first dose within 6 hours of the extravasation.
The sooner the better.
Exactly. The sooner you start it, the better it works.
So is it effective?
Oh, yeah. Studies have shown it really reduces the need for surgery and minimizes long-term problems.
That's good to know.
It's even recommended by all the major oncology organizations.
So it's the gold standard.
Pretty much. Now, there's an interesting thing about liposomal anthracyclines.
Liposomal, what's that?
It's a different formulation of the drug.
Okay.
And those usually don't cause the same kind of tissue damage if they leak.
So you don't need dexrazoxane?
Usually not, just local cooling is enough in those cases.
Interesting. Okay, so what other antidotes are out there?
Another important one is hyaluronidase.
Hyaluronidase. Okay.
And that one's used for vinca alkaloids like vincristine and vinblastine.
Vincristine, right?
And also for taxanes like paclitaxel and docetaxel.
Taxis, got it.
Hyaluronidase breaks down hyaluronic acid. It's the substance in the tissue that helps hold fluids together.
I see.
So by breaking it down, it helps the extravasated drug disperse and get absorbed.
So the body can get rid of it.
Exactly. And it's given as a series of small injections right around the affected area.
Subcutaneous injections.
Yes, under the skin. And it works best if given within an hour of the extravasation.
But it can still help later on?
It can, yeah, up to 12 hours later.
Okay.
Now, important point here.
Yeah.
You don't want to use cold compresses with hyaluronidase.
Why not?
They can make it less effective.
No, so warm compresses are better.
Warm compresses are the way to go in this case.
Interesting.
One other thing to note.
Yeah.
Commercial preparations of hyaluronidase are available.
Okay.
But using them for chemo extravasation is considered off-label.
Off-label meaning?
It's not officially approved for that specific use.
Got it. Okay, so we talked about anthracyclines and vinca alkaloids and taxanes.
Right.
What about the other vesicant drugs? Are there antidotes for those too?
Yeah. So for alkylating agents like mechlorethamine,
Chlorothamine, okay.
the antidote is sodium thiosulfate.
Sodium thiosulfate, and how's that given?
Subcutaneously into the affected area.
Okay, so under the skin.
Right. Then there are some non-cytotoxic drugs that can cause vasoconstriction.
Meaning they narrow the blood vessels.
Exactly, like vasopressors like dopamine, norepinephrine, and epinephrine.
So what do you do for those?
You can use vasodilators like phentolamine.
Phentolamine.
And that helps counteract the vasoconstriction.
By widening the blood vessel.
Exactly. You inject it subcutaneously around the extravasation site.
Okay.
For dobutamine extravasation, you might use topical nitroglycerin or subcutaneous terbutaline.
If phenolamine's not available.
Exactly. They're good alternatives.
Now, the ONS podcast talked about having antidote order sets.
They did. That's super important.
Why?
Because it makes sure the right antidotes are available when you need them.
Like having a toolbox ready to go.
Exactly. And they also highlighted the importance of smaller practices having a plan.
A plan for what?
For getting time-sensitive antidotes quickly?
Like dexrazoxane.
Exactly. If they don't have it on site, they need to know how to get it fast.
So it sounds like having a well-stocked extravasation kit is essential.
Absolutely essential, with all the right antidotes and clear protocols.
Okay, so let's move on to imaging. When is that used?
So for most peripheral extravasations...
The ones in the arms or legs?
Right. You mainly go by what you see and what the patient tells you.
The clinical findings?
Exactly. But sometimes you might need an ultrasound.
When would you do that?
If there's a lot of extravasation or if it's not clear how far it's spread.
So ultrasound helps you see better?
It gives you a better picture of the volume and the margins of the affected area.
Okay, and what about for central lines?
For CVAD extravasation.
Yeah.
The first thing you do after stopping the infusion is get a chest x-ray.
A chest x-ray.
Okay. That helps you check the position of the catheter tip.
Make sure it's still in the vein.
Exactly.
Yeah.
And to assess the integrity of the device.
Make sure it's not broken or anything.
Right. And if the x-ray suggests the catheter might be outside the vein...
Then what?
Then you usually get a CT scan.
To get a more detailed view.
Exactly. The CT scan shows you the catheter's location and if there's any medication in the surrounding tissues.
So if the catheter is not where it should be, that's a problem.
A big problem, and it needs to be addressed right away.
Okay, so what happens to the IV catheter itself after an extravasation?
Does it stay in or come out?
Yeah, what's the protocol?
It depends on the type of catheter.
Peripheral versus central.
Exactly. So for a peripheral IV,
Okay.
once you've done the initial management, like aspirating and giving the antidote,
Yeah.
you generally remove the catheter.
And if the patient still needs IV access,
You start a new one, but far away from the extravasation site.
in the other arm or leg?
Ideally, yes. And sometimes, if they're going to need more infusions with vesicants,
Yeah.
you might consider placing a central line.
To avoid more peripheral extravasation.
Precisely.
And for central lines.
For CVAIDs, the decision to remove them is a bit more complex.
How so?
It depends on a few things.
Oh,
like
yeah.
if the device malfunctioned, how bad the patient's symptoms are, and if they still need central access for their treatment.
I see.
So if there's a mechanical issue with the CVD, but the symptoms are mild,
Yeah.
and there aren't many other options for central access,
Okay.
you might try to repair or replace the catheter at the same site.
Once things have calmed down?
Exactly. But if the symptoms are more serious, like severe pain or skin changes,
Or if the catheter's damaged,
then you need to remove it.
and put in a new one somewhere else.
At a different site, yes.
And if the central line actually perforated a blood vessel.
That's when you need to call in the surgeon.
Okay, so surgery is sometimes necessary.
It is, unfortunately, sometimes even with the best care, extravasations can cause a lot of damage.
Oh, when do you need surgery?
There are a few situations where you'd consult a surgeon,
Okay.
like if there's tissue necrosis,
Tissue necrosis meaning?
tissue's dying,
Oh, wow.
or if you suspect a really large or severe extravasation, or if the pain persists for more than 10 days.
That's a long time.
It is, and if there's any sign of infection,
Okay.
or if imaging shows the extravasation is getting worse.
Or if ulcers develop.
Yep, and if there are complications with a central line.
In the context of an extravasation.
Right, and if there's a mediastinal extravasation
Mediastinal meaning.
in the chest cavity.
Oh, wow, that sounds serious.
It is,
Yeah.
and that requires immediate consultation with a thoracic surgeon.
So you're calling in the specialists.
Absolutely, depending on the situation, it could be a general surgeon, a thoracic surgeon, a vascular surgeon, or a plastic surgeon.
And it's important to get them involved early.
Early referral is key, so they can plan the surgery.
What kinds of surgeries might be done?
It varies depending on the severity.
Okay.
They might do debridement.
What's that?
That's when they surgically remove any dead tissue.
To help it heal.
Exactly. Or they might do skin grafting.
Or where they take skin from somewhere else.
Exactly. They transplant skin to cover the area where there's skin loss. And in really severe cases where deeper tissues are exposed.
Like tendons or bones.
Yep, they might use tissue flaps.
What are those?
They're sections of tissue with their own blood supply that are moved to the damaged area.
So it's like a more complex graft.
You could say that, and some centers, especially for anthracycline extravasations, they use fluorescent dyes during surgery.
Why do they do that?
The dye binds to the anthracycline, and that allows them to see it better.
So they can remove all of it.
Exactly. They can make sure they get every last bit.
That's pretty high tech.
It is. For CV80, extravasation surgery is less common.
But it still happens.
They might do an escarectomy.
Escarectomy, what's that?
That's when they remove thick scar tissue.
Oh, okay.
And then they might do skin grafting or flap reconstruction if needed.
So extravasation can have some pretty serious long-term consequences.
It can, definitely.
What are some of the things that patients and healthcare providers need to be aware of?
So even after the initial injury is treated,
Yeah.
patients can have ongoing problems.
Like what kinds of problems?
They might have persistent pain at the site.
Oh, that's no fun.
Not at all. And they could have sensory disturbances.
Like what?
Numbness, tingling, increased sensitivity.
Wow.
And they might develop chronic ulcers that are hard to heal.
Oh, no.
And